This is Status of States, where we explore health and healthcare across India's diverse regions, with a particular focus on policy, programs, and ground realities. The Indian Constitution lists public health as the responsibility of states. Join us as we speak with health experts from different states, understanding the unique contexts, challenges, and innovations shaping public health. I'm Vivek Devan, your host for this episode of Status of States, brought to you by the Center for Health Equity, Law and Policy at the Indian Law Society in Pune. Let's dive right in. In this episode, we will journey to the state of West Bengal with Dr. Fuad Halim. Dr. Halim is a medical practitioner and social activist, being the General Secretary of the People's Relief Committee and the founder of Kolkata Swasthya Sankalp, an NGO providing subsidized dialysis to marginalized communities. He left a high-profile position in corporate healthcare in 2003 to pursue his mission of better health for all. A frontline warrior during the COVID-19 pandemic, Dr. Halim conducted dialysis procedures during the lockdown, charging just 50 rupees per session, earning acclaim across media and civil society. He is the recipient of the NASSCOM Social Innovation Award, Guidance Guild Award for Medical Excellence, and the Tomake Salam and the Asadharan Awards, recognizing his contributions to public health and social welfare. A passionate science communicator, rationalist, and political activist, he has played a pivotal role in promoting democratic spaces for science and public discourse. Notably, he is the only person in India to have submitted a dissertation on the occupational health hazards of agricultural laborers. We're glad to have you on our podcast, Dr. Halim. I want to begin with the lay of the land, as it were. If you were to describe the state of health in West Bengal, how would you do so? And here I mean health in terms of healthcare, but also in terms of the broader sense of social determinants of health.
Thank you for having me on this discussion. If we are starting to discuss the state of health in West Bengal, then the underlying feature of this entire conversation have to focus on the fact that the government of West Bengal has put a bar on all the data that is supposed to be available commonly in regard to health. The government of West Bengal used to publish a document by the name of Health on the March on an annual basis, in which the entire scenario of health in West Bengal was made available. Since 2018, this document is not available in the public domain. So whatever discussion that we will have to center it around facts that the government of West Bengal have submitted to the central government, to different departments, and the publications made by the central government. Some of the data in acute situations in terms of dengue have been reported by the government of West Bengal to the various news medias and to the courts whenever cases have been put up, and data that has to be extrapolated from other sources. So in West Bengal at the moment for the past 7 years, you could basically say that we are in a no data situation. So given that background, one can start off the conversation by saying that we are in a data poverty situation, and the data in terms of health is very unhealthy here in West Bengal. But having said that, if we look at the state budgetary allocations primarily, then you will see that the state government documents that are submitted to the assembly, the budget speeches, also points in a downward direction in terms of how the state is allotting funds for the health. For example, if you look at the budgetary allocations for 24-25, on one of the heads, that the budget detail of capital expenditure for social services, the Health and Family Welfare Department had a budgetary allocations of 2,868 crores. But for the subsequent year, that is for the year 25-26, the budgetary allocations have gone down to 2,699 crores. So that's a reduction of almost 268 crores in terms of capital expenditure year on year. If we go into a bit more detail, then you will see that the budget statement has 3 heads in which financial statements are made. One is the budgetary estimate, that is for a particular year, the government estimates that this is what we are going to spend. And the subsequent year, after the year is ended, you have a revised estimate. The government assesses that most probably it has spent so much. And then the subsequent year, you have an actual expenditure, That's called an AE, where the government says that 3 years ago, this is what has been actually spent. So if you take 1 year as an index, that is the year 23-24, then you will see that the outlay of West Bengal was 18,489 crores. That was the budget estimate. The government, in its revised estimate, submitted that it had spent approximately 17,958 crores, an immediate downgrade. But in the actual of 23-24 submitted this year, it further goes down to 17,226 crore rupees in the outlay. So already you see the budget estimate and the actual expenditure has been downsized by almost 1,200 crore rupees here in West Bengal. So the positioning of the government in regard to health and what it actually does is many a time way off by about 7 or 8% in budgetary terms. So that is where we are here in Bengal. If you look at the social indices, for example, then you will see that the maternal mortality, which was in a quite a healthy position in West Bengal, has been going down. And that is one of the most serious indicators that we are looking at. And if you look at the maternal mortality figures, compare them to the All India figures, then we come to a very, very sad picture over here. For example, in 2007 to 2009, because maternal mortality figures are calculated over a 3-period span, the All India figures were 212 mothers we were losing. And in West Bengal, for the same subset population, we were losing 145 mothers. Subsequently, the All India figure went to 178 and Bengal reduced to 117, and it goes on to 167 for India and 113 for Bengal. And then suddenly in 2016, we get the All India figures that 113 mothers we are losing comparatively to 98 mothers in Bengal, which now flips because in 2017-19 period, Bengal now has an increase from 98, the MMR figure, it goes up to 109. And the All India figure goes down from 113 to 103. This is the crossover period where the maternal mortality in Bengal crosses the All India average. So the progress and the advancement that Bengal had accumulated has not only been spent out, but the rate of maternal mortality has undergone a reversal. That is, not only has it stabilized or plateaued, but it has started to increase in West Bengal. So there are multifactorial reasons of that. If you look at the infant mortality rates also, our All India position that we were holding, we've lost that position. And not only that, Bengal has moved from the 15th All India position held in 2010 to the 21st position. So our infant mortality rate has pushed us back, even though comparatively year on year, we've been able to reduce our infant mortality. But the speed and the rate at which the India and the other states have been doing work, Bengal has lagged behind. So this gives you just a snapshot of how, starting from the budget to the social indices, in terms of how our health situation comes across. It was a robust and healthy state, but over the past decade and a half, we've spent our advantages and we have accumulated disadvantages. So that is broadly where we are.
That's very interesting and also rather tragic in terms of infant and maternal mortality statistics. I'm particularly interested in the issue of the bar on data and the fact that there is a lack of it. This lack of transparency in the way public health is being governed, or even how planning around health is being done, is something worthwhile spending a bit of time on. What is the impact that it has then on programs, Dr. Halim? Clearly, numbers around maternal and infant mortality pre-2018, which were on a good trajectory, are not so anymore. What other impacts does a bar on data have in terms of how health can be planned in a state, how allocation of both human and other resources can be properly done, and what are the implications of this at an individual level?
Take one issue, for example, if we look at dengue, the importance of data is that if you have got an outbreak in a particular geographical location, then you immediately need to allot resources and focus and try to encircle or have some sort of anti-larval, anti-malarial and anti-mosquito measures in areas where dengue and malaria raise their head. Now, the problem is that until 2018, the data in the Health on the March was very, very precise. We had the state level data, we had the district level data, And we also had data that went below the district level. So a particular practitioner, for example, whether he be in the government sector or in the private sector, he had this data available to him as to whether his area is having a spike of dengue or whether his area is having a spike of malaria. It helped him in concluding a clinical diagnosis because he knows what's going on in his area. Now, that is severely impacting the way that we've been able to identify and plan for diseases. Also, at the public health level, if this data is not available, if it's not available only to the public, but also not available to public health specialists, then how do they plan their trajectory in terms of delivering healthcare services, especially public healthcare measures, in terms of taking care of an outbreak that needs to be contained as soon as possible? Now, one has to keep in mind that we had a serious dengue outbreak around 2005 and 6. There was a serious spike then, and the health department and the government took an initiative to actually control dengue. And if you look at the data that we get from Health on the March from 2008 up to 2018 that is available, and subsequent data from 2019 2023, you will see that the data in these 5 years comes from either the National Center for Vector-Borne Diseases or from newspaper clippings or for submissions made by the government to the court. And you will see these figures are astounding because in 2008, given the spike in 2005 and 6, the total number of dengue cases in Bengal were 1,020 and the number of deaths was 6. In 2009, it goes down to 399. With no deaths in 2009. And 2010, it begins to now slowly rise, 805. But in 2011, again, because of that rise, the government became active and it went down to 510. But now from 2012, you see the figures are ratcheting up. It goes to 6,456, 5,920, 2013. It goes up to 8,470 in 2015. And 2016, we see a blast. We see 22,865 cases, which go to 2019, 45,000 cases. And we lost 40 people. In 2023, now this data is not coming from the government anymore. This data is coming through the newspapers, through the submissions made to court. Bengal had a figure of 76,000 dengue cases, and we don't have any figures on the death because the government has not revealed it. So data is important in terms of assessing what the magnitude of the problem is, and for diseases like that are vector-borne disease to find the geographical locations, because dengue now in Bengal is from an urban disease to the semi-urban disease. In many geographical areas, we're finding dengue is penetrated into the rural area. Now, if we don't have data, if we don't share data with the private practitioners who are practicing in various areas, if we don't share data with the public health officials, Bengal is facing a serious crisis in terms of government employees. We are short-staffed by about almost 10 lakh people in the government services, and a large portion of these shortages are also in healthcare delivery systems and people in public health, the basic work of in terms of anti-vector-borne activities and all these things. So if the data is not shared, even wherever there is that supplementary manpower and infrastructure, how do they stimulate themselves to become active at times when it is essential? So data is absolutely essential. Data also gives you an idea as to how the healthcare services are performing here in West Bengal. Because if you look at, for example, the cataract operations, which is a vertical program that comes down from the central government and no money is spent by the state government, what is the utilization capacity? For example, if we look at the National Program for Prevention of Blindness, the data that is coming, the number of cataract operations, then we will see in the period between 2001 and 2010, and if we compare it to the figures that are coming from 2011, 2018, then we'll see a stark contrast. In 2001, 84% of the fund allocators were utilized. In 2002, 104%. In 2003, 106% of the target operations were conducted. In 2005, 130%. 30% more cataract operations were done. And that excess amount of money was extracted from the central pool because the performance rate of the government sector was wonderful. But once we come down to 2010 and 11, still we are having 98%, 102%. But 2011-12, it starts deteriorating. It goes down to 75%, 65%, subsequently 54%, 51%, 47%. So data is actually telling you that in Bengal at the moment, the share that Bengal can actually extract, deliver healthcare services in terms of cataract operations to the people of West Bengal from the central port is almost half of what can be extracted and achieved. And if you look at it in terms of public health terms, those many people are actually going around West Bengal with blindness that is absolutely avoidable, treatable. So I think so data gives you an idea as to how resources are being mobilized, how healthcare delivery systems are working, whether they are working efficiently or not, and it also gives you an idea as to what's going on in Bengal in terms of the health indices that are there. These are, I think, so the basic reasons why data suppression has now become a very, very important tool for the powers to be, so that people don't understand, people cannot assess what is happening in terms of performance here in West Bengal in terms of health.
So, a couple of follow-ups just quickly on that. One is, was this something which also was reflected during COVID? This lack of data and lack of sharing of what's going on through COVID, especially those years of 2020, 21, 22. And secondly, is there related to that a demand from civil society? I mean, West Bengal has a strong tradition of movements and civil society and exercising your democratic rights to obtain information and other things. So, is that something that has also been attempted in West Bengal? And I'm also wondering, why would the government suppress this information unless there was something to hide?
Absolutely. During the COVID period, we've seen that the government tried to take policy decisions which were divorced from the ground realities, and it fumbled a number of times. It announced the Calcutta Medical College to be the apex center for COVID, but then from pressure that came from within the system, especially from the medical college's internal leadership, the government had to revert back, and we didn't have a nodal center, referral center for COVID right through our entire COVID period here. We had a team of people who were considered to be the COVID specialists who would monitor and ensure that policies flow out, which will be implemented by all health structures. Now, I mentioned that particularly because as an index case to get an understanding of what happened during COVID. So, the opacity in terms of data remained. The number of people who have died because of COVID, that data is still not available publicly. We've got this difference in terms of the felt reality and the actual occurrence of COVID, because one has to keep in mind that here, I believe that in other parts of India also, the very poor and the very marginalized, the way the dead bodies of their near and dear ones, especially in the initial phase, were not being handed over to their relatives, made them very, very apprehensive. And they looked upon government hospitals with anybody having a symptom of a cough, a fever, and respiratory distress as being a one-way gateway. The poorest of the poor, they went into a very, very alternative situation. That is, they would connect with a general practitioner or some doctor who was connected with the area. They would treat the patients at home. And the basis of that understanding was that if the patient died, then that doctor or that professional would give a death certificate so that they could dispose the dead bodies themselves. They had reconciled to a reality that they are COVID positive. If they survive with the few medications that are being given, well and good. If they do not survive, at least we have the right to dispose our body out here. So there, I think so, the government, not only in West Bengal, but all over India, I think so, failed to make that connect with the poorest of the poor, where the government hospitals and the healthcare infrastructures would be seen as welcoming in terms of not only treating the patient, but also being very, very sensitive if the patient passed away, in involving the relatives of the patients in the last rites. As I mentioned earlier, the data in terms of COVID deaths were very, very opaque. The beds availability in terms of a patient coming from outside Calcutta or in Calcutta to a government hospital, whether he would get admitted or not admitted, the government made an attempt to have some sort of platform where bed availability, oxygen availability, medication, other resource availabilities would be there, but it didn't work very, very significantly in favor of the patients accessing those data and actually on ground realities where patients had to run from several hospitals. And we have these incidents of many patients dying on the way without getting admitted. So all that scenario worked itself out in background of this lack of data, lack of sharing of data, and basically policy poverty at that instant. where a huge challenge came about, and the healthcare services were not only inadequate, but whatever resources that were there were not consciously planned for and optimized in terms of giving what could have been given at that point of time. On the other question that you mentioned, that yes, the government does have a stake in suppressing data, especially as I mentioned earlier in terms of dengue deaths. So the past 6 or 7 years, the annual number of people died because of dengue is unfortunately not available directly on any public platform. So health being a politically very sensitive issue, failure of the government that is slowly coming across through the data up to 2018, I think she was consciously stopped by the government so that the negative data that the government itself was publishing would not become something that could be used to hold the government accountable. The third part of your question is this civil society raising these questions. Globally and even in India, health is not a central agenda. During any elections, it's not central agenda for various political parties, other than a few of them who included not only during the election manifesto declaration, but also in between elections in other policy documents. There are very few parties, the communist parties that are there that link health as an agenda. Otherwise, it's not a major agenda of that. Bengal has had a very, very strong civil rights movement, but other than in pockets and in certain areas, health is not an agenda. We do have movements in terms of right for the civil forces workers here. You've got some movements in some districts and parts of certain districts. The blood donation movement does have a strong voice here in West Bengal. But collectively, in terms of a right to health movement, the right to data in terms of health, those movements are not very, very strong here. And those voices are not organized at this point of time. That's a vacuum that needs to fill up.
Thanks, Dr. Halim. That was a very insightful and eye-opener for sure. I think it's true that health is not a political issue, not just in West Bengal, but largely in the country. I think it's been hard, even post-COVID, to drum up any kind of sense of what political parties by and large feel and what their commitment to public health is. Even in the last general election, one didn't see anything particularly powerful from most manifestos. I do want to come back to the short staff aspect that you mentioned in government services generally, and particularly in health services. But I also want to speak a little about health infrastructure. In West Bengal, I've come across quite a few papers which suggest that there is a skewed availability of healthcare infrastructure in the state. A lot of it is concentrated in the city of Kolkata, less so in the more rural contexts. And therefore, that also then creates geographical disparities of health outcomes. Is this accurate, and why this lopsidedness? And what needs to be done really to address it then?
There are parts to it. One is the philosophical part of it. And the second is the actual ground reality in terms of where we are. If you look at the philosophical part of it, the thrust of the present entire global narrative in terms of health is that you need to have universal health coverage. You need to have government responsibly limiting itself, arranging curative health for its citizens. The preventive health, the promotive health, the all-encompassing health for all concept, which was Alma Declaration, has changed after 2000, where we didn't even have an obituary in terms of why we could not achieve our goals. We had declared for the entire world in 1978. We achieved by the year 2000. Then globally targeted our Millennium Development Goals to be achieved, in which more or less we realized we couldn't, and we again reallocated ourselves the SDG goals by 2030. But what happened in terms of the paradigm shift, which policy terms globally came to West Bengal, was that we moved from the health for all concept centered around the primary health center to a concept where the government would just take care of insurance. And that increased. And not only has the government financing has gone down for health in West Bengal, but whatever is being allocated, a portion of it growing in size is being allocated now to service the insurance policy system, and the government health system is weakening. Financially, its reflection is there in terms of the manpower also. So we are understaffed in terms of doctors, we are understaffed in terms of nursing staff, the other categories of healthcare professionals, right up to GDS. So these vacancies at the end of the day are going to impact the person who's going to walk into a government hospital. So the bathrooms are not clean. When he goes to acquire his medicines which have been prescribed by the doctor, if he gets a doctor And then pharmacist is not going to be there. I'm not talking about quality. I'm just talking about the physical presence. Quality we can discuss later. But in terms of exactly what we are having in terms of shortages in healthcare, is that if you look at, for example, the optometrists in Bengal at the moment, the vacancy is almost 226, that is 44.93% vacancy for optometrists here. If you look at the medical officer vacancy, that's almost 15%. If you look at the medical officer specialist vacancy, that is almost 35%. If you look at a simple sweeper's post in the whole of West Bengal government hospital structure, vacancy is 68%. So we do not have 68% sweepers that are supposed to be there. And what the government did was to re-employ the ex-sweepers, and that ex-sweepers post that's supposed to be filled up, that has almost a 70% vacancy. So the original posts are vacant, and now the re-employed people, those posts are also vacant in humongous numbers. That creates a service delivery gap. And in terms of policy, I would say is a very, very conscious trend. It's a global trend which filters down through India to the state of West Bengal. We've seen these vacancies come up, and if the person who's supposed to sprinkle the anti-larval powder or the medicine is not there in his position, then that area is going to have the potential of a dengue or a malaria outbreak. If the sweeper is not there, then the emergency, the ward, toilets are not clean, and definitely we do not have the doctors in adequate numbers, then treatment care and protocols are going to be violated. But having said that, one also has to understand the establishment table is basically the number of staff, human resource that have been calculated vis-a-vis the number of beds and the physical infrastructure. And these vacancies are according to that establishment table. Now, the first establishment table that we had in West Bengal was made in 1947. Which was subsequently upgraded in 92 to 96, 4 years to upgrade that. And we were supposed to now have an upgradation of that establishment table from 2012 to 2016, which has not been done. So these vacancy figures are actually in context to the table that was created almost 35 years ago. So we are already lagging on our upgradation of the table. Given that old table, we are backed by almost 60-70% vacancies in our healthcare delivery staff. It's very difficult, and this data could only be made available through an RTI made by some of very, very positive thinking people, because the government is absolutely tight-lipped. And of all the 213 categories of staff that are there in the healthcare delivery system in West Bengal, the RTI could only extract information and data in terms of 18 categories of staff. The other categories of staff, the data is still not available, even though RTRs are high.
This is obviously dire numbers here. So 2 questions. One is this reflective of tertiary care, secondary care, hospitals in the districts, hospitals in the city? And how do PHCs work in this context? Are they also understaffed? A, and B, does this also mean that people are being hired in the private sector and those jobs are fully covered?
Yeah, this is purely in terms of government employment in those categories across the board, across West Bengal, in tertiary, secondary, and primary healthcare centers, wherever these posts and positions have been sanctioned by the government of West Bengal in terms of the establishment table way back in 1996. Some of these positions they've tried to fill up with contractual staff, but one has to keep in mind, for example, the medical officer category, the nursing category. Some of these categories cannot be filled up by contractual staff. Some of the ICU posts and the SCUs and the neonatal sick child units, those are some positions where medical officers are also being taken on contracts, but it's on a center-to-center basis. It's not a policy prescription. It's more of a knee-jerk reaction. If one center becomes absolutely having no staff, then at that point of time, the government allows for some contractual staff. The GDA category, that is the non-sweeper category, the ones who do the security and all that, most of that has been outsourced to the private sector. The laundry, those categories of staffs have been outsourced to the private sector. But how many of them are still there in the government sector? Those data we've not been able to get through the RTI. So basically, it's a mix and match situation of the, as I mentioned earlier, the 200 plus categories that are there. Some of these categories have been identified to be outsourced. But some of the categories cannot be outsourced for the very nature of the category that it is. For example, a nursing position can't be outsourced on a contractual basis. In context of the tertiary center and the primary health center, the government of West Bengal, classical system of having the three-tier system, the primary and secondary and the tertiary system, has been slightly disrupted with the political motive of declaring that we are going to have super specialty hospitals. Now, Bengal has a new category of tertiary healthcare in terms of 42 super specialty hospitals. Primarily, these hospitals are being staffed with the people who have been shifted from the lowest tier of the healthcare system, that's the primary healthcare system. They are being cannibalized to staff these 42 super specialty hospitals. So you have to understand that the staff numbers have not grown, but there has been an internal reorganization. As you mentioned very correctly, that what happens to somebody accessing help. So if the primary health center staff is now demobilized to the super specialty centers, then the healthcare delivery patterns in the primary health centers are impacted. Access to health in terms of distance now increases. There is a tendency to say that we are giving very good services in the super specialty hospitals, but one can understand that not a single cardiological procedure in terms of an angiogram has been performed at any of the 42 super specialty centers. Not a single neurological procedure, not a single endoscopy has been performed of there. So you have specialists coming from the medical colleges, visiting these super specialty hospitals maybe once a week, but procedures are not done out there. And OPD may be held, that also in a very irregular pattern. So basically, an unplanned tire has added itself to the healthcare delivery system here in West Bengal. Physical infrastructure is very beautiful. The buildings look wonderful. The floors and sitting arrangements look very wonderful. But for even a complicated delivery, somebody would get referred from a super specialty hospital to maybe an old previous district hospital or maybe Calcutta. That's another disruption that has come into our system, which has contributed directly to weakening the primary healthcare system.
So these super specialty hospitals have been set up by the government. Is this the government hospitals or are they public-private partnerships? So what's the nature of the setup actually? And also, when did this idea emerge?
These 42 super specialty hospitals are government hospitals at the moment. This idea emerged somewhere around 2013, 2014. Just prior to the elections, they were declared with much fanfare that had more of an electoral appeal to it. The follow-through of that is that once these super specialty hospitals have been set up, the government and one section of the government is seriously thinking of hiving it off the private sector. But there is serious political ramifications of that. So I believe that the government will not decide that. But the government is being able to staff these super specialty hospitals with needed staffing patterns that are required to deliver quality healthcare in terms of what a super specialty hospital should do. And at some point of time, I think so, as globally and nationally we are privatizing government infrastructure, these assets may be privatized through the weaning process of the public-private partnership in terms of diagnostics and other deliverables. So all the advanced diagnostics are already in the hands of the PPP players here, and they are slowly creeping into healthcare delivery also. Dialysis, you could say, is also an area where the predominant presence is of the private players within the government set up through the PPP models that have been established here. This transition politically is a position that cannot be taken by the government, I feel, at this point of time. But practically, it is slowly weaning. I think so Bengal will lag the all India picture in terms of how aggressive the government will be in hiving off its assets to the private sectors in terms of time scale because of political reasons here in Bengal and the strong left that is there, which the government is definitely very sensitive of. The public opinion then turns around against the government for that.
So I'm going to jump to another point you made, the issue of quality being another larger perspective. Could you touch on the issue of quality? You said that would require its own answer.
You see, quality in terms of healthcare has various dimensions. For the patient in Bengal, in a peripheral rural area, first criteria of quality would be accessibility. If a patient cannot access a healthcare delivery institution, then to actually talk of quality in terms of what is being given out there then become secondary. Now, Bengal went through a phase in the 70s and the 80s where our physical infrastructure in terms of the primary healthcare centers in Bengal were very sparse. So we've seen the 70s and 80s and till the early 90s, where the primary focus of the healthcare delivery system in terms of the government looking after it was to spread the physical infrastructure. So if you go to the national database that is there, in terms of the physical infrastructure, in terms of the primary healthcare center and secondary healthcare center, you will see Bengal has a very, very good position in terms of whatever the targeted numbers that we are supposed to have. But come to the staffing pattern, you will see a reversal of that picture. So the physical infrastructure there, the staffing patterns are not matching. Now, those service deliverables are being squeezed. The quality of services that a primary healthcare center should be providing in terms of the national planning and the state planning. We know state health as its subject, but the national government has a role of playing the steward in terms of which direction our healthcare systems go, and they have some national programs that are deliverable right at the primary health center, at the sub center, the ASHA worker, and the other multi-purpose healthcare workers that are there. They're supposed to deliver. Now, those issues are seriously compromised because the ASHA workers, they're paid very poorly. Their job of actually providing the routine immunization, taking care of the mothers, and those things are being compromised. And as I said earlier when I spoke, when the maternal mortality in Bengal is turning upwards, which is a very peculiar trend, because we might have some sort of plateau, but an upward trend tells you that we are in a sub-Saharan or maybe place which have very, very poor healthcare services with acute war-like conditions, where you see this, what do you term in terms of quality over there? So quality means that the person who is delivering these care services and the person who is receiving it, they have some agreement that this needs to be done and it's being done, and the target that needs to be achieved is being achieved. So those issues are now compromised and quality of that is being impacted. I believe is being done consciously, because when a person enters a government hospital at the tertiary center, or a person is supposed to receive care at home through an ASHA worker or an Anganwadi worker, or a child who goes to school and is supposed to get a healthy meal, the larger perspective of health, where a nutritious meal is the key to make healthy individual and citizen, this entire perspective of quality is being compromised. Because politically, I think so, the thrust which comes down from the global flow through India into West Bengal is to weaken the government healthcare delivery system and open the doors for the private sector. The medical inflation is almost 14 to 15%, whereas general inflation varies between 4 to 8% in our country. So year on year, if you are investing in health, you are going to make a larger packet. The government has already decided through policy prescriptions that medicines will increase their costs by 10% to the advantage of the pharmaceutical industries. And you've got the Medical Council of India, which now oversees medical education to such an extent that now we have private medical education occupying almost more than 60% of the entire medical education spectrum in our country, which was not so. It was not only opposite. When I started my medical education, then 90% of medical education was in the government sector and only 10% was in the private sector. Now, given those changes that are taking place, quality in a government hospital becomes an issue of choice for the people. And if you want people to choose the private sector, you need to reduce the quality in the government sector. And I think so that's the policy perspective that is being followed here in West Bengal, which is in tune with what's happening overall.
May I ask you, in relation to just generally governance of healthcare institutions, West Bengal is one of the few states which has actually got its own Clinical Establishments Act. I'm wondering if you have any sense and any views on how that statute has been implemented, whether it has been useful in actually bringing accountability and transparency to healthcare delivery, and what do you see generally the role of the law being in being able to actually contribute to a more equitable experience?
The Clinical Establishment Act here in Bengal has gone through 3 phases of evolution. So we had our old act, which was then upgraded in 2002, and subsequently it was upgraded in 2016-17, and the rules have been framed there. Now, the Clinical Establishment Act per se has a role to play in regulating the private sector, because the act is not relevant or not implemented for the government sector here. This implementation has, to a certain extent, streamlined basic facilities that maintain quality in the private sector, and the government has applied its mind in that direction. But what it falls short of in terms of the protecting the rights of the citizens. So the healthcare deliverables that are Here in private sector, the patient's rights charter or the patient's rights in terms of what is negotiated on the table for delivering healthcare is still not something that the Clinical Establishment Act has focused on. It definitely has a regulatory authority to oversee any dispute, and that regulatory authority has a number of complaints pending with it. But it's like catching your nose from the back of your head, because only when you have a dispute and you have the resources to follow up with the dispute do you end up putting an application to the redressal mechanism. The government itself being proactive in protecting citizens' rights in accessing healthcare. For example, if there's a package that is decided upon, and if the costs escalate beyond the package, then what is the responsibility of the healthcare providing structure and patient is something that is still opaque and unclear. So you might end up negotiating a package for a gallbladder operation for about 35,000 and maybe end up paying about 70 or 80,000 at the end of the day when you're going to discharge your patient and take him or her back home. Now, how does this work itself out? Which mechanism resolves this? It's the Clinical Establishment Act that should have proactive role in ensuring that this happens. Secondly, for example, if you look at many institutions here in Bengal, they do not accept blood from blood bank that is outside their hospital premises. And the blood that they provide from their own blood banking services, they charge a premium. Now, that is already something that needs to be addressed by the establishment very clearly, because if you're trying to get medicine or blood products from any pharmacy or any place, that should be allowed to be used on the premises of a particular hospital. But those are areas where the Clinical Establishment Act and its implementation in actually addressing the problems on the ground have not worked themselves out. Definitely has a limitation in terms of the new technologies that are coming in and how the rights of the patients are to be protected in terms of data, in terms of consent. So those are finer areas where legal needs to apply their mind. But by and large, the body of responsibility that the Act needs to address is that when a common man engages with a private institution in getting a service from them, how do they protect themselves in terms of cost, quality, in what's being promised to them, whether that is at the end of the day being delivered or not? That is seriously lacking for a couple of reasons, because the Act is not engaging with civil society. I would believe it's a very conscious way in which the government of West Bengal is not telling people and making them more aware in terms of what their rights should be. Those are areas where the private sector, which has grown humongously, needs further government intervention to regulate them and to make them accountable. And these are two areas where the Clinical Establishment Act and its implementation is seriously falling short.
Dr. Halim, you talked about the common man's experience with healthcare. I wanted to ask you, I know that West Bengal has not adopted the Pradhan Mantri Jan Arogya Yojana, but it has its own Swasthya Sathi health insurance scheme. How is that played out? You talked, of course, earlier about the idea of Alma Ata and how universal health care has suddenly become universal health coverage in the last 20 years. But in that context, is insurance a method through which people are actually able to seek the sort of financial aid that they require?
The insurance concept coming to health is something that came about massively after the first economic meltdown of this century. And the economic downturn that took place, that started off in 2006 and continued for a couple of years, its effects are still persisting, some say, taught, I think so, finance capital two great lessons. One is that of all the sectors that underwent a reversal, there were two sectors that did not suffer the impact as much as the other sectors. One was health and the other was the education. Education being an expense that the present generation invests in the coming generation. So people are less likely to be miserly in spending on education for their young ones who are going to be the next generation. The second sector was health, because health globally is an expense that nobody can postpone. If you're getting a heart attack, you are going to break your fixed deposit, you're going to sell your land, and that's what most poor people, middle class people and other people do. You break your pension fund to actually solve your healthcare financial needs as soon as possible. You cannot postpone these expenditures. So we've seen this huge glut of financial institutions and global bodies move into health post 2010, 2012. In India and also in West Bengal, by the time 2014 came about, you had the private sector build huge hospitals up to the district level. So we've seen in Bengal at least 4 or 5 district level huge complexes come up by these corporate bodies, but they were not having patients. And you look at the Association of Hospitals of India, the reports that started coming about in 2014 and 15, they were saying that we've got installed capacity which is underutilized by almost 35 to 40%. Then you've got the RSBY program, which was about 30,000, overnight jumped to about 5 lakhs. National PMJY program. The Bengal follows suit with the same matching amount coming about in 2016-17, and then you had the footfall in these corporate sectors. So basically, it was a corporate hospital structure which had built huge infrastructure, wanted profits, which wanted people to come in and deliver profits, but the poor people of India did not have that financial capacity, and the government became an agency for transferring its funds in the name of sick people to the corporate sector. So that's basically my perception of what insurance is all about, and Bengal does not have any other story. In terms of what the people face over here is that they are facing huge challenges in accessing this government insurance scheme. So co-payment has now become part and parcel of the system. And if you've got to do a gallbladder operation or a abdominal hysterectomy, then you have to pay over and above what is available on your card to access or to complete the entire healthcare delivery process. The second thing that has happened is that these centers which are actually servicing the health insurance, they're basically based in the districts. So the services that were available in the periphery, now for the common man to access the same services, they have to now move to the district headquarters, which is added burden in terms of travel, in terms of staying at the district headquarters to get an appendectomy or any other operation that is there. Definitely, you've got a huge amount of funds which are illegally being siphoned off by these private sector and corporate hospitals, to that extent that the government had to actually put a moratorium and stop certain forms of treatment and remove them from the Swasthya Sathi system. For example, hernia and hydrocele operation were removed through the Swasthya Sathi system. You will have to go back to the hospital and get that done. Cancer chemotherapy seriously reduced centers. The government has notified, I think so, 2 or 3 centers. So access issues have exacerbated because of this, because now if you want cancer treatment through Swasthya Sathi, you have to travel to those couple of centers that are available here. Same with acute treatments that are available in terms of trauma. You need to get a clearance, you need to get the government involved with the decision making before it's actually sanctioned and you can get yourself treated. So orthopedic operations, a number of these have been removed from the list. So one has to be very clear that what Swasthya Sathi actually started off with, 8 years down the line, it is not the same bouquet of services that are being delivered through that card. And the government setup is seriously suffering because of the budgetary allocation has not only been reducing, but portion of the pie is also being removed for servicing the insurance schemes. The entire situation is really, really serious in terms of delivering healthcare services. I'll end by saying, for example, if the health card and you have a particular incident, if you have a chronic disease, for example, like chronic kidney failure, and you've been admitted and you've been discharged, treating institution will keep your card back until the sanction and clearance doesn't come. And if you require subsequent services as a continuum of care, require subsequent dialysis, then because your card is submitted and the clearance is taking time, your continuum of care is being impacted. So these are micromanagement issues and larger macromanagement issues in terms of policy, whether in the larger picture, in terms of actually delivering health for the people who are disadvantaged, it is not playing as great a role as was in SARS.
Dr. Halim, thank you so much for so much interesting perspective. I do want to ask you one final question because I think you've laid out the challenges quite clearly. And what strikes me is this is a lopsided situation of great inequity in West Bengal on almost every front, from human resources to allocation of budgets to the ways in which planning is taking place, etc. If you had to offer a different path for health in West Bengal to take, what would 1 or 2 measures be which could take us on a more equitable and more fair path?
Well, I'd be very clear that in terms of improving health indices and the social determinants of health, then one has to have a synergy across various departments if you're looking in terms of government. And I think so education department would have a very, very important role in creating a citizen who are conscious about their health. The second would definitely be public health engineering and the food supplies department, nutrition and good drinking water and covered drainage. Those are the areas in which actually the bulk of the disease can be controlled. And definitely the health department play a very, very important role. And the health department, I think so, the mainstay and the backbone globally, wherever third world countries and developing countries have actually been able to impact health diseases, is to invest in healthcare workers who door to door create consciousness toward the living connection with society, investing in ASHA workers, in Anganwadi workers, in multipurpose healthcare workers, in carrying information which are helpful, in identifying patients who have risks not only in terms of pregnancy but also of the non-communicable diseases, and identifying areas which are potential having communicable diseases in terms of vector-borne diseases, having a strong network of information from the villages themselves, from the peripheries of society, with people who are adequately able and prepared to face the challenges in terms of identifying them and providing solutions at the last mile, and building up on that, creating the primary health center as the pivot around which a healthful society evolves, with the medical officer team over there and the other categories of staff empowered to actually take decision, so that 90% of problems which can be sorted out at the primary healthcare center and below are sorted out there, where our secondary healthcare systems and tertiary healthcare systems now have to deal with only 7 or 8% at the secondary level and 2 to 3% of the problems tertiary level. At this point of time, we are working in a reverse mode, where we've got more people coming to tertiary care centers and our peripheral centers have been dried down. We've got a system that's physically adequate, needs to be empowered in terms of human resources. We need to change the policy prescription from a top-down model to a bottom-up model. And I think that's the only way ahead to create a country which is healthful and healthy.
On that forward-looking note, thank you for sharing these insights based on your vast experience in West Bengal and for such an enriching conversation, Dr. Halim. Thanks for joining us for this episode of Status of States. Stay tuned for more such conversations. This is your host, Vivek Devan, signing off.